Dr. Manmohan, and all the participants who are attending today's class. Dear student, today our speaker is Dr. Manmohan. Dr. Manmohan has done DNB, MRCP UK, EDIC UK, IDCCM. His designation consultant, intensivist, and in charge AHRC hospitals, Ranchi. His area of interest is in nephrocritical care, neurocritical care, endocrine emergencies. The class is over to you.
Yeah, good evening all. I'm Dr. Manmohan. I'm working as an intensivist at Ranchi. It's my pleasure to be part of this wonderful course. And I must say that when I applied for my EDIC, I did not have a luxury of this kind of courses which could help me to clear my exams. But you guys are definitely lucky that you are having this kind of courses material available at your footstep, and so that you can prepare rapidly in a shorter duration of time while working in intensive care. So it's really difficult to give separate time for the preparation of the exam. So this kind of courses really definitely help us, and this Farz Academy is doing wonderful job for the last few years, and they have constructed this courses to help you to clear EDIC 1 with the minimal efforts with the maximum output. So thank you Farz Academy for allowing me to be part of this wonderful course. So we'll start. Today's lecture is all about fluid and electrolytes, and we all know how important this topic is and how favorite it is for the EDIC examiners. There will be 5 to 10 questions from fluid and electrolytes, whether you talk about EDIC 1 or you talk about EDIC 2. EDIC 2, definitely there will be 1 or 2 questions of sodium abnormality or potassium abnormality in biochemistry. So today our primary focus is EDIC 1, so we'll focus on that. This talk is divided in 2 halves. One is fluid and the other is electrolyte. So let's start with the fluids. This is the outline for the fluid section. We all face these questions on daily basis: why to give fluids, when to give fluids, what fluid to give, whether crystallites or colloids, what colloids among the colloids, how much fluid to give. Very pertinent questions we face day-to-day basis. Whether giving the fluid, is my patient is responsive to what is the fluid I'm giving, is he, the more important, is he tolerant to the fluid I'm giving, and the last but not the least, when to stop the fluid resuscitation. So let's start with the case. You can see the 62-year-old lady with a community-acquired pneumonia admitted in ICU with a fever and multiple opacities on X-ray. She's in respiratory distress. She was intubated. Despite of giving 30 ml of kg of fluids, 2 liter of boluses, initially she was persistent. Her blood pressure was in lower side. Her MAP was just 45. Her CVP was 10, and her oxygen saturation SCO2 was 89%. Lactate level was 7.2, and her urine output was quite low. That is just 10 ml per hour. So what will be which is the following statement is the best step in the next management? The best step, the next management. So just go through the options. We'll answer this question in later part of the talk. So is it the best option is starting an norepinephrine and perform PLR to assess the fluid response rate? Is it starting a dopamine? Is it continue fluid resuscitation till we reach a CO2 of 12 centimeters of water? Or is it that patient is already in respiratory distress, we should not have given 30 ml of kg fluid boluses? And because SCO2 is more than 70%, oxygen delivery is her tissue is adequate, ignore the MAP, and no additional fluid should be given. So these are the options. We'll answer this question at later part. So we'll start why and when to give fluids. So how do we approach shock? First of all, we question ourselves, is there a shock? Is there a true hypotension? And how severe is a shock? Whether it is grade 1, 2, 3, 4. Is the patient is able to compensate? In early stage, patient will be able to compensate for the shock. The more important, giving fluid will improve my cardiac output. It's not just the increasing the CVTD. Are you able to convert your fluid boluses into increase cardiac output? That is more important. And is giving fluid harming your patient? Is he able to tolerate the fluid boluses? And should I add inotrope or vasopressors at this point of time, or should I wait by giving few more boluses? So this is the general approach we follow for the shock patients. So how do you assess the patient's volume status? How do you assess whether the patient is able to, whether the patient is in mild to moderate category of shock, or whether he is able to compensate? We assess the vital signs, we assess his MAP, we assess the patient. If he's in shock, the MAP will be low, less than 60, 65. He'll be tachycardia 100, 120. Physical examination is very important. They say urine output is a poor man's cardiac output. So urine output is very important. The target is at least 0.5 ml per kg per hour. That should be our lowest target for the urine output. Mental status, there could be a GCS of 13, 14. Capillary fill time may be more than 3 to 4 seconds. Extremities will be cold. Skin turgor will be dry. Labs, the most important marker for the hypoperfusion is a lactate. BNP I have deliberately mentioned here. Just if the patient is not tolerant already in heart failure, the BNP could be high. So you'll be skeptical giving fluid boluses in high BNP patients. Non-invasive monitoring, it's very, very important in today's modern era. We call ultrasonography is a modern stethoscope for modern intensivist. So we can do everything and anything with ultrasound. Even if you don't have stethoscope, but you have ultrasound in your ICU, that will be more than important than stethoscope. Though stethoscope is important, but ultrasound is currently it's very important. I recommend everybody have ultrasound in their ICU. You can assess IVC whether it's collapsing or dilated. We can assess the lung. We can assess the heart, RARV collapsing or not. How is the LV function? We can perform diagnostic maneuvers like a passive leg raising test, and we can see whether the patient is fluid responsive or not, whether giving the fluid boluses will help for this kind of patients. And invasive monitoring, though we don't do it on regular basis, but we should know, for example, like a CVP, pulmonary capillary wedge pressure, pulse pressure variation, stroke volume variation, and cardiac output. CVP. Going ahead, this was one approach suggested. We call it as a trifocus approach. We routinely do cardiac ultrasound and lung ultrasound, but the hepatic ultrasound, which is a venous Doppler, the VEXAS grading, which is upcoming thing. Many of us are not trained in this, but this is very important for the assessment whether the patient will able to tolerate the fluid. Maybe the patient is in shock, but there might be hepatic congestion. So instead of giving fluids, we may need to support him inotropes and may need a diuretics rather than giving fluid boluses for this kind of patients. So trifocus approach is upcoming thing. We should be knowing about this. We can assess three things: lung ultrasound, cardiac ultrasound, and hepatic. We can assess hepatic congestion by doing VEXAS grading. So we have done a why to give fluids. The patient must be in shock. When to give fluids? Why we have done when to give fluids? There is definitive intravascular depression. The patient has a low cardiac output state, but he is fluid responsive as well as he is fluid tolerant. And by giving fluids, I should be able to increase the stroke volume. Not just my target is not just to increase the CVP. It should turn around. It should increase the LV ejection fraction, and definitely it should increase our stroke volume and cardiac output. That's our ultimate goal. Why? We want to achieve the better perfusion of peripheries and vital organs. We improve the perfusion. And at last, giving fluid should always outweigh the benefit. So risk should be outweighed because there is a higher risk of pulmonary edema. And we are going to discuss the detrimental effects of fluid as well in the latter part of the talk. So I'm not going to in detail, but the benefit should be outweighed the risk. Any talk on fluid would be incomplete if we don't talk about this landmark trial which came in 2001. Rivers et al. Did a protocolized approach. What they did, they fixed the targets for CVP, MAP, and SCVO2. The CVP target was at least of 8, the MAP target of at least of 65, and SCVO2 the target 70. What they did, they form a protocolized approach. We call it as early goal directed therapy. The other name for this trial was EGDT trial. So early goal directed therapy, they targeted MAP of 65. They gave fluid boluses of 20 to 30 ml kg of crystalloids, and they targeted MAPs. If the MAP is still low, by giving this 20 to 30 ml of kg of fluid, then they started them on vasopressors. If the CVP is less than 8, they persistent on fluids, and to keep a SCO2 of 70%, they've even given a blood transfusion. This was EGDT. For many years, we followed this trial, but it was to be practically, it is really difficult to monitor SCVO2. Though we can perform CVP by through our central line MAP, it's very easy if you have arterial line, but SCO2 is day to day, it's really difficult. So this This trial was questioned by 3 landmark trials which came in 2014, which is Process, Arise, and Promise. I'm not going in detail about all these trials. I'm just going to mention them and what was their conclusion, what they suggested, what should we do. There is no definitive consensus as of now, and every few years the consensus get changed. So I'm going to just mention these landmark trials and what are the important highlights they have told us. I'm going to just talk about that. So this Process trial was done in US, Arise was done in Australia, and Promise was done in UK. And they compared this EGDT, they followed EGDT therapy in one group and other usual care, like a standard of care, that would like what we do on day-to-day basis. We target lactate, we target MAP of 65, we try to bring down the lactate as early as possible to less than 2 millimoles per liter. That's what they did. And importantly, they found no mortality difference between two groups, between the EGDT group and the standard care. So this was the comparison between those 4 trials. You can see the EGDT trial showed improved mortality where they followed MAP, CVP, and SCO2. But in Process, Arise, and Promise, EGDT versus usual care, here in the Process trial, they did plus minus of SCO2 CVP monitoring, but there was no mortality difference between EGDT versus standard care. Same with Arise and Promise trial. There was a then the meta-analysis came in 2017 about these 3 trials, which told us that if we do EGDT protocolized approach, we'll have a higher expenditure regarding intensive care. We'll utilize more resources about it. And with the current scenario, with a limited bed capacity, with a limited intensivist in our ICU, the resources should be utilized appropriately. So greater use of resources in intensive care and definitely higher cost. If you go ahead with SCO2 monitoring and safety monitoring, all those other things will additionally add burden on the patient and patient's family. So after this trials and after this meta-analysis, many of us went back to our standard approach. But definitely EGDT led us to EGDT trial, made our mind, it directed us that what should we do in early phase. Definitely it helped us to resuscitate fluid patients in early stage rather than just giving 10 ml per kg and all that. Okay, so we have done why and when. Next is what fluid to choose, either crystallite or colloid, what among the colloid versus crystallite. So crystallite, normal saline, ringal lactate, 5% dextrose, and plasmolite included in a crystallites. And colloid group will include albumin, starches, and gelatins. So first we'll talk about this saline versus albumin. These are the 2 landmark studies came in 2004 and 2014. SAFE trial and Albios trial, must have heard, everybody must have heard of this trial. SAFE trial, they compared 4% albumin with a 0.9% saline. So there was no mortality difference at 28 days between 4% albumin saline versus normal saline. And the other trial in 2014, they compared 20% albumin, what we routinely use in 20% albumin in our setup. So 20% albumin versus crystallite in severe sepsis, albumin replacement in addition to crystallite as compared to crystallites alone did not improve survival, neither at 28 days nor at 90 days. So what this trial suggested that if the patient is not affordable with a low economic strata, what we face in India commonly, if the patient is affordable, yes, we can consider albumin, but there is not much of mortality difference. But the only advantage they follow with albumin, what we assume that as it is a hyperoncotic, it helps to retain more fluid in intravascular component. One more secondary outcome from this trial was the albumin should be avoided in TBI patient, which can lead to hyperoncotic, which can lead to cerebral edema. So that's what they suggested. So this was the outcome from SAFE and Albios trial. So based on this trial, what we understood that we can go ahead with the saline resuscitation alone rather than considering albumin. What should we choose between crystallite versus starch? So starch is out of favor so many years because of so many multiple trials in the last decade, YSAP study, 6S trial, CHEST trial, crystal trial, and all these studies favored crystallite as the fluid of choice in critically ill patient, and that's what we do in regular basis, because starches increases the incidence of AKI, the requirement of renal replacement therapy, and eventually it will increase the mortality. So that's why the starches went out of the favor. What about what to choose among the crystallites, whether normal saline or balanced salt solution like a linear lactate or plasma light. So these are the 4 important studies which came, which compared normal saline versus balanced salt solutions. Split trial, salt ED, smart study, and basic is the recent one which came in 2021. Out of this 4, only one study, which is smart study, showed benefit of balanced salt solution. The other 3 studies did not show any mortality benefit. So though we are like focusing more on balance of solution, but still there is a lot of question whether we should utilize this balance of solution on regular basis, or whether we should resuscitate our patient with balance of solution from the beginning itself. That's still a question mark. But it's very case to case, very intensivist to intensivist. It's individualist practice what we can choose whether to give normal saline versus balance of solution. So among this 4 trial, you can see only the smart study which showed lower composite outcome death, lower incidence of AKI, renal dysfunction, and lower requirement of renal replacement therapy. Salt ED, there was no mortality difference, no difference in incidence of AKI. Same with the split trial, and the last one is the basic. Even they did not show a difference among those 2 group, plasma like balance salt solution versus a normal saline. Going ahead, so till now we have done why, when, what, how much. So I think everybody will agree that at least though the surviving sepsis guideline have suggested go ahead with the 30 ml of kg per kg in first 3 hours, but many of us are very skeptical giving 30 ml of kg in first 3 hours. But that's what suggested by surviving sepsis guideline in 2021. If you compare the 2000, this is 2000, the right side is a 2016 recommendation, and just a minute. Yeah, and the left side is a 2021 recommendation. So in 2016, the recommendation was strong, but in last few years, the concept has changed to some extent, and the recommendation has become a weak. So they suggest at least 30 ml per kg of crystallite in first 3 hours for the resuscitation. So what's the problem with this 30 ml of kg, 30 ml per kg? What's the problem with that? Can anyone say? What's the problem with that? This 30 ml per kg, giving 30 ml per kg fluid in first 3 hours?
Too much.
Yes, please answer.
Too much, sir.
Too much? Yes, agree, totally agree. And what could be the other problem? Maybe less?
Yeah, less 4 kg.
Yes, true.
4 ml per kg.
Yes. So the big problem with this 30 ml per kg in first 3 hours is that it could be too much for few patients based on their requirement, maybe, or it could be a less, maybe under resuscitation in some patient, or maybe over resuscitation in some patient. So what is the ultimate line? One size does not fit at all. Okay, and reassessing the fluid requirement after 3 hours, isn't it too late? Because we just give 30 ml per kg, like consider 60 kg of man, 30 ml per kg would be around 1.8 liters. So you'll just give 1.8 liter over 3 hours. We cannot just walk away and assess the patient after 3 hours. That will be too late. So this man, I'm a big fan of his. So Professor John Lewis Tubel always comes up with something new regarding the fluid administration. I'm a big fan of his work. He's not a big fan of this 30 ml per kg. He always talk about the individual approach. You must have heard his talks recently. He delivered talk in Critical Care 2023 at Indore, and he had a talk in AHRC as well. So what they suggest, rather than just going ahead with 30 ml of kg, 30 ml per kg in first 3 hours, what they suggest, you should start with 10 ml per kg. We should start with 10 ml per kg of crystallite for the first hour. We should assess at the end of 1 hour if the patient still requiring more fluids, that the capillary time is prolonged, there are still signs of hypovolemia, the MAP is still low, the extremities are still cold, and the source of sepsis is abdomen, and there is evident fluid loss. You will increase the fluid rate from 10 ml per kg to, you can go up to 15 ml per kg. That's what they suggest. But the other side of it, if there is an increased oxygen demand, if there is a tachypnea, there is a desaturation, you should reconsider going ahead with the 10 ml per kg of fluid. We should cut down the infusion rate. That's what That's what they suggested in this study, and this is what we do. This is what I do in my ICU. I always reassess them at the end of 1 hour, and based on that I can decide how much fluid to be given in next 2 to 3 hours. We can always assess bleed load responsiveness. We have the studies. We're going to talk about how to assess the bleed responsiveness in the upcoming slides. So just from this slide, always what we can gain, that always try to focus on individualized approach rather than just saying that one size fits all, giving 30 ml per kg for all the patient in first 3 hours.